So good morning, everyone, and thank you for coming. Today we are going to be discussing something that I think many of you maybe don't appreciate as much, but now that we have an EP specialist in our department, we see great results when we treat many of these patients with arrhythmias, especially tachyarrhythmias, who had presented with cardiomyopathy. So today, Kabo, one of our fellows, is going to be discussing an approach to this condition and how to manage it. I also do have Dr. Mkoko, who's our EP lead here. So during the Q&A session, we can go into more details how we should approach these patients, treat them and manage them. So without any further delays, just invite Kabo to come and take the platform. I believe you will just go forward with this exam. Okay.
Morning, everyone. My name is Kabo, as I've been introduced, from the Division of Cardiology. We'll be looking at this often forgotten reversible cardiomyopathy, and to let's go. To kickstart our discussion today, we are going to look at 4 patients that we took care of over the past few months, just to illustrate this often forgotten cardiomyopathy that we're talking about. The first patient that I want us to look at is a young lady with dilated cardiomyopathy. Came in quite symptomatic with quite impaired effort tolerance. She was functional class 3 New York Heart Association. And on imaging, she had a dilated left ventricle with a depressed ejection fraction, otherwise normal valves. This is her, let me just go back. This is her ECG. I think you can appreciate that it is a tachycardia. She's running a fast rhythm here. It's a narrow complex, and it is also irregular. If you compare the first RR interval to the subsequent ones, you can see that this is a clearly irregular rhythm. And then the next question that we ask ourselves is that, is there P-wave activity? And you can see on the rhythm strip here that there is actually just no clear P-wave activity. So one of the students, do you know what the diagnosis is from this ECG? Great, so this is atrial fibrillation. So this patient was appropriately managed for atrial fibrillation. She had multiple DC cardioversion for the atrial fibrillation, had been started on beta blockers as well as anticoagulation, as is recommended by the guidelines. And the second patient, also young, with no comorbidities at all, came in with a long-standing history of palpitations. And on presentation, we found that she also, like the first patient, had heart failure symptoms with impaired effort tolerance, functional class 3. She was importantly at this point already optimized in terms of heart failure medication. And similar to the first patient, this one also had a depressed ejection fraction. This is her ECG, or his ECG rather, which again shows a tachycardia. It's narrow complex. If you look at all these QRS complexes here, this is narrow complex. So it's a narrow complex regular tachycardia. Then the next question that we want to ask ourselves is that, is there P-wave activity? And I think you can see that for every QRS, there is a preceding P-wave. You can see that clearly on the rhythm strip. However, I want you to pay attention to the inferior leads, lead 2, lead 3, and AVF. You normally would expect to find upright P-waves in these leads. And on AVR, both the QRS and the P-wave should be negative. So the presence of negative P waves in the inferior leads actually tells us that this actually is not coming from the sinus node. So I would like one of the registrars to just tell me what the diagnosis here is. It's a narrow complex, regular tachycardia, but we are seeing that the P waves in the inferior leads are negative. So this is an atrial, it's an atrial tachycardia, okay? So yeah, we're saying this thing is not coming from the sinus node, great. Then the third patient, middle-aged with a background of diabetes and hypertension, came also with heart failure symptoms, and on presentation was dizzy and had syncopal episode. So unlike the first two cases which I showed, this one was not running a tachycardia. You can see that for every QRS, there is a P wave. You can see there's a P wave there. There's another P wave there. But what you can appreciate are these premature ventricular complexes. And whenever you see this in an ECG of somebody who is symptomatic with palpitations or syncope and all that, you need to say, look, I'm taking a snapshot and doing a 6-second ECG, but how many of these rhythms does the patient actually have on a day? So we proceeded further now to order a Holter to quantify the burden of this premature ventricular complexes, and we found that it was 30%, which is quite high. Essentially, what it's telling us is that this patient has about 30,000 of these activities on a daily basis, which is quite a lot. Then the last patient that I want us to consider was also a young patient with HIV controlled on treatment. Essentially came to us with double valve, which was of rheumatic etiology. He had severe mitral stenosis, as well as moderate aortic regurgitation. At the time of presentation, this patient was already in heart failure. I think the guys going for exams will recall that if you get a severe lesion like this, severe mitral stenosis, or any other lesion, and the patient is already symptomatic, this is a class 1 indication for intervention. So this is a patient that clearly needed to have valve surgery. The problem with this patient was that his ejection fraction was right on the floor, 20%, which makes him a high surgical risk. So we know that we need to intervene, but the outcomes for these patients have not been so great. So unfortunately, after discussion with the surgeons, he was turned down. He was not accepted for surgery. And essentially what that meant was that you'd be palliating this patient. Just look at his ECG. You can appreciate that it is regular, narrow complex, the QRS there. In terms of the P wave activity, you can see there's multiple P wave activities here. If you look at the inferior leads, there's downgoing sawtooth pattern. You can appreciate in V1 as well that they are upright. So this is an atrial flutter. This is what, just to illustrate that depressed ejection fraction, echocardiography there, you can see this is the left ventricle. It is hardly contracting. You expect a nice good squeeze to show that systolic function is preserved. Otherwise, I'm not going to go through the rheumatic changes on this echocardiography. So now, all these 4 patients that I've just presented to you have 2 things in common. The first thing is that all of them came in with an arrhythmia, one arrhythmia or the other. The first case was an atrial fibrillation, and I showed you atrial tachycardia, premature ventricular complex, as well as an atrial flutter. The second thing is that common denominator is that this patient presented with heart failure and had some form of cardiomyopathy, which brings us to today's topic of cardiomyopathies. I think this definition of cardiomyopathy, which is about 18 years old, is still relevant even to this day. So this consensus document identified key things that you need to look at for you to say, this is a cardiomyopathy. So these are heterogeneous groups of conditions of the myocardium, which are associated with mechanical or electrical dysfunction. And often they exhibit ventricular hypertrophy or dilatation, which is inappropriate. And then lastly, you would then classify them and say, these are conditions either confined primarily to the heart, or they can occur as part of a generalized disorder. There has been work done in this field regionally. A few years ago, Karen Sliver and colleagues looked at the epidemiology and etiology of cardiomyopathies in Africa. And I think you can see that from their paper here, they identified a number of things, untreated hypertension, infectious etiologies. You can look at autoimmune, metabolic factors, genetic, nutritional, as well as pregnancy. This is quite a long list. So what you then need is to have an approach so that you put the things in the bags and you know where to classify them and Even when asked a question about cardiomyopathies, you can classify them nicely. So the starting point then is to say, a patient with cardiomyopathy, it can be a primary cardiomyopathy or can be secondary cardiomyopathy. The word primary cardiomyopathy should not be confused with a familial or genetic. It does not mean that. So what primary cardiomyopathy means is that the disease is primarily confined to the heart. You understand? So primary cardiomyopathy would be primarily the myocardium, whereas the secondary cardiomyopathy, which is the second group here, these are systemic conditions. If you look, for example, at, say, under toxins here, alcohol. Alcohol is a systemic disorder. It can, in the heart, can cause cardiomyopathy. In the liver, can cause cirrhosis. In the nerves, can cause peripheral neuropathy and all that. So that's where the distinction comes from. So examples of secondary cardiomyopathies would be, storage, toxins. You have to think about endocrine, such as hyper or hypothyroidism, infiltrative disorder, inflammatory disorders, as well as neuromuscular. So for primary cardiomyopathies, the key things is to say, are they genetic or acquired? And these are the specific examples. And then in between, you would have the mixed group, such as restrictive cardiomyopathy. So the topic that we are focusing on today, which is tachycardia-induced cardiomyopathy, also referred to as arrhythmia-induced cardiomyopathy, falls under this category. So it is a primary cardiomyopathy which is acquired. As I said, the word arrhythmia-induced cardiomyopathy is often used interchangeably with tachycardia-induced cardiomyopathy, or other experts call it tachymyopathy. Some people actually prefer us to use the word arrhythmia-induced cardiomyopathy simply because I think, as you can recall from the examples that I started with, that there was a case of premature ventricular complexes. The patient was not running a tachycardia. They just had an arrhythmia. So even in the absence of a tachycardia, you can still get a cardiomyopathy, and hence some people leaning towards just say it's an arrhythmia-induced cardiomyopathy. So it is characterized by systolic dysfunction and clinical manifestations of heart failure. And the hallmark of this condition is that it is reversible with normalization of heart rate. First case was described roughly 100 years ago in a young patient who had atrial fibrillation with a rapid ventricular response. This patient was found to have unexplained left ventricular dilatation and heart failure, which raised questions, and subsequently there were more work done on this field. So in the typical form, the arrhythmia is the only underlying disorder, and the left ventricular systolic dysfunction is fully reversible. It's important to know that pre-existing structural heart disease, so a pre-existing structural heart disease, the arrhythmia may actually aggravate left ventricular systolic dysfunction, and hence it just renders it partially reversible. Then the next question is that which arrhythmias cause cardiomyopathy? So it's important to, first of all, classify them and say, when you have a patient with arrhythmia, it can be coming from above the ventricle, which is supraventricular, or below, which is ventricular. And then we then further divide this to say supraventricular can be atrial or nodal. And this will be the specific examples that one can look at. Let's see, I think one does not project in there. Atrial fibrillation, flutters, and all the other supraventricular arrhythmias, and then ventricular arrhythmias. An example would be frequent premature ventricular complexes. How common is this condition? So the exact incidence is really unclear. However, we know that there seems to be an association between tachycardia and cardiomyopathy, which has been recognized for some time. And visually, really, any tachyarrhythmia that we may think about may be associated with cardiomyopathy. So the insights about the epidemiology of these conditions really has been obtained from patients who've undergone a technology which we are fortunate to have now in Charlotte called catheter ablation. And these are really patients who have been referred to undergo ablation. There are several cohorts that I want to just give an examples of. First one was where in a group of more than 300 patients referred for ablation of incessant atrial tachycardias. They found the incidence of depressed myocardial dysfunction to be just about 10%, and most of these patients were younger, frequently male as well. In this one, they found the incidence to be roughly about 3%, and the third one about 14.5%. You may look at these figures and say, this looks like it's a rare condition, but that's not the case. So remember, these studies that I'm looking at, it's cohorts from first world where patients present early. You know, somebody comes with palpitations or syncope, they get investigated and treatment initiated on time. Our experience over the past few months when with EP services being available at Charlotte now is that we frequently have late presentations, and we estimate that in the few patients that we have done, the prevalence is way higher, ranging between 30 to 40%. So I think it's something that we are missing, and we seriously need to start thinking about. Then how exactly does this come about? Let me just try to get a pointer. Right. In terms of the pathophysiology, so the key thing, the triggering thing is a persistent tachycardia or an arrhythmia, which then causes a neurohormonal activation in terms of the brain and atrial natriuretic peptide activation, as well as activation of the RAS and the sympathetic nervous system. What you then get is a heart failure phenotype with depressed ventricular function, reduced cardiac output, increase in the wall tension, and left ventricular dilatation. We know that there is a relation between this because frequently when this patient get determination of the arrhythmia, they often go back to their pre-morbid state. So the information from in terms of the pathophysiology of this condition has really been obtained from animal models. What we know from studies in this experiment is that persistent tachycardia causes a number of changes. It causes some morphological as well as biochemical changes. And what this does then is called, you get a number of changes. Firstly, persistent tachycardia causes depletion of myocardial energy stores. And the evidence for that is that there has been found to have reduced levels of ATP as well as myocardial creatine with diminished sodium potassium ATPase activity. And this is thought to come about as a result of alteration in cellular metabolism with mitochondrial injury and increase in the Krebs cycle oxidative enzymes. The second thing that you need to look at in terms of the persistent tachycardia that it does is that it causes an abnormal calcium handling with beta adrenergic responsiveness. And this then causes downregulation of beta-1 receptors in the myocytes. Thirdly, persistent tachycardia would cause oxidative stress and injury in the myocardium. And that in turn then modifies the protease in terms of the myofibrils. And then lastly, there seems to be a genetic predisposition in that patients with angiotensin converting enzyme polymorphism who have higher levels of this enzyme and the 287 base pair incision or deletions. And importantly, those with the phenotype of DD seem to be more predisposed to developing this condition. And just to illustrate this at a cellular level, this picture on your left, just starting off with the normal myocyte and the extracellular components. If you can look at this, the basement membrane and the sarcolemma, this is what you would expect to be a normal myocyte. with good amount of extracellular metrics. If you then get sustained tachycardia, this is what you then get. It causes loss of a basement membrane and subpalliamal interface with diminished extracellular metrics. And in turn, that then causes loss of the myocyte alignment and failure of ventricular performance. I think you can see it illustrated in this picture. If you look at the extracellular metrics as well, compare this picture with the one on the left, you can see the significantly diminished extracellular metrics. And then thirdly, in terms of the calcium, there's loss of the L-type calcium channels, which then causes abnormal excitation contraction coupling. And then lastly, oxidative injury with destruction of the mitochondria and alteration of the proteins. Just to illustrate this further, to show that, you start off with a normal heart, normal undilated heart that contracts well. Then you have a trigger, which I think, as we're saying for today's topic, is an arrhythmia or a tachycardia. Whether you have a tachycardia here or, if it's atrial fibrillation or frequent premature ventricular complexes. The mediators then there would be calcium mishandling, and it causes a number of effects, which at the end causes a dilatation of the heart, and you get this dilated cardiomyopathy. With suppression of this arrhythmia, and I will come to this towards the end of the presentation, either through medication or ablation, you often get improvement or reversal of cardiomyopathy. Enhanced hearing, this is an often reversible, this is a reversible cardiomyopathy, which we often forget. And there seems to be a bidirectional relationship between these cardiomyopathies or heart failure and the arrhythmias. If you look at an example of atrial fibrillation, we know atrial fibrillation can cause heart failure, but also heart failure through the remodeling process, often fibrosis and neurohormonal activation causes atrial fibrillation. And then you can also go the other direction as well. We know that in atrial fibrillation, there is loss of the atrial kick, tachycardia with abnormal heart rate, with the rapid ventricular response causes a depressed cardiac output, and then you get atrial fibrillation-induced cardiomyopathy. So how do these patients present? So the cardinal symptom, the cardinal presentation is actually palpitations, heart failure, and syncope or pre-syncope. Will be then, how long does it take between one presenting with the palpitations and the syncope and all that to them developing a cardiomyopathy? It actually varies, but the figures that are really quoted on the studies there is it can take anything between a month and years from the initial presentation of arrhythmia. So what this essentially tells us is that you can get a patient who comes now to you with palpitations and syncope, is not in heart failure. So that patient is not out of the blue yet. So just because they don't have heart failure symptoms at the moment does not mean that they do not need to be treated. And this condition should be suspected in all patients with newly diagnosed left ventricular dysfunction without obvious etiologies, or those with prior or persistent or frequent paroxysmal tachycardias. Patients with underlying structural heart diseases and tachyarrhythmias should not be excluded because they may also have a coexistent component of arrhythmia-induced cardiomyopathy. You might recall from the cases that I started with that there was a patient who had severe mitral stenosis with a moderate aortic regurgitation and atrial flutter and with a reduced ejection fraction. So it could have been easier to just attribute that depressed ejection fraction to the valves. But obviously, when you look back, you have to say, but should mitral stenosis cause such, significant deterioration in your ejection fraction, or are we missing anything else that might be contributing? So with previous normal left ventricular function or left ventricular dysfunction, disproportional to the degree of underlying heart diseases, you have to think about the possibility of arrhythmia-induced cardiomyopathies. And the evaluation should include common diagnostic strategies recommended for contemporary heart failure. Essentially, what this is telling us is that you have to manage this patient as any other patient that comes to you with a heart failure syndrome or cardiomyopathy. I showed that the flow chart or the diagram to about all the differentials that as a physician you have to think about. And essentially what this is telling us that, you know, you should think about all the other possibilities. And hyperthyroidism can facilitate arrhythmia-induced cardiomyopathies. How long does it take for this patient to recover? In animal models, in whom you try to induce a tachycardia with rapid pacing, what we've seen from the studies is that when you cease pacing, basically terminating that arrhythmia, the left ventricular systolic function often improves within 2 weeks. And then the most of the hemodynamics return by 4 weeks. However, there is no guarantee of a complete recovery of an enlarged left ventricular volume or dilatation and hypertrophy. In clinical studies, what we have noted is that improvement of left ventricular systolic function often occurs within about a month of the treatment of the tachyarrhythmia. And the recovery of the left ventricular function can take between 2 and 3 months. But usually by 6 months, you expect some form of recovery. In our experience with a few patients that we have taken care of here, most of the time by 3 months, there is marked improvement in terms of their systolic function. How do you manage these patients? Restoration of normal heart rate improves left ventricular systolic function and reverses the clinical manifestation of the heart failure. So the cornerstone of managing this patient is to achieve normal heart rates. Because as we showed in the pathophysiology, the tachycardia or the arrhythmia is actually what drives this process. So if you start off with a patient with a systolic function that is depressed, is in heart failure, manage this patient as any other patient with heart failure. And that means, this is more important for the students, a patient coming to you who's got a heart failure syndrome, that means you need to take a detailed history that should include family history as well, because you want to establish if there could be any familial cardiomyopathies that you're dealing with. Detailed physical examination, also trying to establish if there could be any other, any generalized if this could be part of the secondary cardiomyopathy, for example, features of hyperthyroidism, could this be alcohol related, is the patient cirrhotic and all that. So as a physician, you need to start off broadly and approach the patient as such. ECG is very important because that's one of the things that will alert you to a possibility of this condition. Obviously, also on history, you would have paid attention to the presence of palpitations, syncope, pre-syncope. So if that happens, then you get an ECG, and then it might then alert you to the possibility of an arrhythmia, of which then you need to treat appropriately. I will show it in the subsequent slide. There will be cases where you do an ECG, you don't find anything on the ECG, but that should not make you dismiss the possibility of an arrhythmia causing this. If the patient clearly has got palpitations and syncope and all that, you then have to think about doing a Holter, which essentially now is to say, rather than looking for an arrhythmia over a 6 seconds period now, do monitoring over 24 hours. When this patient presents you for the first time, say you are the med-reg on at casualty, there are 2 important questions that you need to ask yourself. Firstly, what is the hemodynamics of the patient? Is this a hemodynamically stable patient or unstable patient? For example, you may have a patient who presents for the first time with atrial fibrillation, going rates of 200s, they are hypotensive and all that. So you need to manage those patients as per the SV SVT guidelines. Think about cardioverting the patients, loading them with amiodarones and all that. Then the second important thing that you need to consider is on examination, is it a patient who's in heart failure? And you need to manage that appropriately. Obviously, the definitive management would be drugs and catheter ablation. But if there's presence of heart failure, I just want to refer you to just refresh your mind to the heart failure guidelines. This is the 2021 guidelines. You would have obviously assessed the volume status of the patient. If it's a patient that needs aggressive diuresis, you do that. And definitively, we know that these are the 4 cornerstones of heart failure medication. ACE or an ANI, a beta blocker, a mineralocorticoid receptor antagonist, and the new keys on the block, which is SGLT2 inhibitors. So you're getting a patient with a cardiomyopathy or LV dysfunction. As I mentioned, you obviously want to make sure that you are not missing any other causes of heart failure. So detailed examination and evaluating for that. Then if the patient is in failure, you initiate heart failure medication, get an ECG for this patient, which might confirm that there is a tachyarrhythmia, or there might be no tachyarrhythmia on that ECG, and then you, for example, find that the patient has premature ventricular complexes, which you then need to quantify over a 24-hour period with a Holter. And the magic number, the significant burden of premature ventricular complexes is 10%. So if that's the case, then obviously then we send these patients for ablation or we treat them with arrhythmias, of which most of the time you will get normalization with the left ventricular ejection fraction. Or if this was an arrhythmia superimposed on another etiology of cardiomyopathy, you might just partially get improvement of the ejection fraction. So I've been mentioning this catheter ablation a lot. Now just to make mention of, to just touch base on it briefly. So this is the new technologies that we have. And I think as I mentioned, we've been doing it here at our hospital now over the past few months. And how well does it really work? Is there evidence for that? If you look at this study, the camera MRI study, which looked at catheter ablation versus medical therapy in patients with atrial fibrillation. So compared to, these were the patients who were just treated medically. And then when you compare them to patients who underwent catheter ablation, you can see that there's like a 4-fold improvement in the ejection fraction if this patient underwent catheter ablation. And so from this, what you can appreciate is that, or what the authors concluded was that restoration of sinus rhythm with catheter ablation is associated with considerable improvements of the left ventricular ejection fraction, cardiac remodeling, and functional capacity. The second arrhythmia that one can quickly look at is premature ventricular complexes and ablation. And I think what you can see again is that in this study, ejection fraction of this patient's pre-ablation compared to post-ablation, clearly there is marked improvement. I can see most of the graphs that's going up there. And the big number there that they found was 24%, that we have burden of PVC more than 24%. Most of them develop cardiomyopathies. The third one that I want to quickly look at as a wrap up is atrial flutter. And in this systematic review, where they looked at 65 studies, what they found is that when you treated flutter with catheter ablation, there was up to 80% normalization of the ventricular function with this ablation, which I think is quite impressive. This is a very good number. We have something that can actually offer cure, and the success rate is quite high, 80%. For atrial tachycardia, I just want you to quickly look at this. This is just a case study there that they look. There's a patient with lupus, systemic lupus erythematosus. been there for some time, also came in with quite symptomatic, initially diagnosed as sinus tachycardia, but subsequently, referred to an electrophysiologist who then found that this was actually focal atrial tachycardia, not sinus tachycardia. The patient ablation, and there was improvement of the ejection fraction, doubled from 30 to 60%. So just coming back to our cases as to what really happened, the first patient that I presented had atrial fibrillation. He underwent ablation, and 4 months later, the patient is back in sinus rhythm. It's moved from New York Heart Association functional class 3 to class 1. The ejection fraction has in fact doubled from 30 to about 60%. The second patient who had atrial tachycardia also underwent ablation, and likewise, has been in sinus rhythm, doing well now, asymptomatic, and back to their pre-morbid state. The third patient who had premature ventricular complex, likewise had an ablation and is doing very, very well. The last one, I think, as you might recall, that was the patient with atrial flutter who had a severe mitral stenosis. I'm just going to show here. This is the patient who had a severe mitral stenosis with a depressed ejection fraction, had indications for surgery, but unfortunately could not be operated on because of his ejection fraction being very, very low. So he also underwent ablation, and we have moved from this to that, which is quite a marked improvement. This patient has since been presented to the surgeons, and they are very happy to operate on him. I think this is a good success story. So I hope that through these 4 cases, we have demonstrated to you that all these patients who had arrhythmias have had their cardiomyopathies and their low ejection fraction being reversed. So arrhythmia-induced cardiomyopathy is reversible. The diagnosis requires a high index of suspicion, and you need to consider the diagnosis in patients with unexplained systolic dysfunction and any form of tachyarrhythmia. And lastly, heart rate normalization with rate or rhythm control is a cornerstone of therapy, and it may result in improvement or normalization of systolic function in about 4 weeks. And as I've mentioned, these 4 patients that I show, most of them by 3 months had really just gone back to being normal. Thank you very much.
All right, thanks, Kabo. That was very inspiring to see these excellent outcomes. But just to put it back into perspective again, maybe I'll put the question to Peter, our EP lead here. Which patients should we consider who present with this, and perhaps we've missed the boat? Ablation may not really achieve much improvement. I mean, we're giving you here patients, or showing you cases where we've had excellent outcomes, but I presume there are cases where one may do these procedures and not get these outcomes that we've seen here today. And I just want you to prime the audience so that you don't get on the arrhythmia clinic, 500 referrals of patients for ablation to treat their cardiomyopathy. So which patients are almost like we've missed the boat? Can you maybe give the audience some insights to that?
So it's a funny story, right? Because I actually believe that every patient that we see is an opportunity at sinus rhythm. So generally, if when we are talking about atrial fibrillation, for example, if we leave a patient in AF for longer than a year, chances of us being successful in keeping them in sinus rhythm are very, very small. So when we take someone with paroxysmal AF and we take them on for catheter ablation, we have an 80% chance of being successful. But once the patient is in AF for longer than a year, that drops to 50%. So I was actually say, when we see the patient for the very first time in atrial fibrillation, why can't we actually try sinus rhythm early on? So if we try early, then we are more likely to be successful. Let's just think about it that way. Everyone deserves a chance at sinus rhythm, and we should push for that. The law would mandate everything that the less
All right, so what you're saying, Phil, is that patients who've had chronic long-standing, especially here, you're talking about atrial fibrillation specifically, those patients who may not be able to reverse it.
Yeah.
Any comments?
The other hate to see atrial flutter, atrial tachycardia, PVCs, we need to see those.
Is to be referred to. We will tackle them, we will treat them, potentially cure them with ablation. But those chronic long-standing atrial fibrillation, we may not be able to reverse those patients. Again, I'm opening to the floor and online if there are any questions. I see there are chats here.
One question from Zamo. Is there a role for ablation in CMOs more than one cause, e.g. hypertension or diabetes?
Yes and no. So atrial fibrillation cardiomyopathy.
Online.
Oh, yes, that's what I'm thinking. Yeah. Sorry.
So arrhythmias and heart failure, they tend to be sort of a funny relationship in the sense that one leads to the other, right? So if you take someone who has a dilated cardiomyopathy, these patients, as the dilated cardiomyopathy worsens, they're likely to develop atrial fibrillation. But again, leave the atrial fibrillation forever without the cardiomyopathy, they're likely to come with heart failure. The question is then, when we see someone who's in atrial fibrillation and has a cardiomyopathy, which one came first? Which one is the egg? Which one's the chicken? Now that's a tough one, right? It's very difficult to determine which one came first. But the clue is, if we have someone who's got heart failure and has an arrhythmia, particularly atrial fibrillation, can be anything, but is modestly dilated, the chances are that is an arrhythmia-induced cardiomyopathy. When we see people with dilated cardiomyopathy and AF as a complication, usually the LV is very dilated. But when we have AF causing cardiomyopathy, the LV is not so dilated. And then that gives us a chance to say that we can actually get this patient back. So some people have looked at MRI, right, to say, when we have a patient that comes in with heart failure and arrhythmia, those that have heart failure causing an arrhythmia usually have extensive scarring on MRI, but the reverse is true when we have those patients that have AF or an arrhythmia leading to heart failure, they have less scarring, which tells us that we can get, unfortunately for us, we don't have access to MRI, right? So it's gonna go back to my first statement then to say, everyone deserves a chance to sinus rhythm. So how are we gonna do this then in our context? So what I would do, it comes a dilated heart in the AF and I'm seeing for the first time, I'm gonna anticoagulate them for 4 weeks, direct current cardiovert them and see what happens. If they feel great after the cardioversion and there's some improvement, we are just gonna go for it. We're gonna go for catheter ablation.
Two more questions. Is there any need for further antiarrhythmic drug use after ablation in patients with arrhythmia-induced CMO?
No. Particularly when we're talking, so if you've seen the patients that Kabo presents, we actually present young folks, right? 36, 37. These are young people. And one of the reasons why some of them come in, they don't want to be on drugs. So if we can offer them that would be good.
Yeah, can you just discuss what about anticoagulation? So you've talked about antiarrhythmics.
Yes.
What about anticoagulation post treatment of arrhythmia?
Yeah. So we're gonna depend. So in the past, right, there were a couple of studies that looked at just slowing down the heart versus sinus rhythm, which one is better? And erroneously, they come back and say nothing is better. You know what they did? When the patient went into sinus rhythm, they stopped the anticoagulation and the patient actually died from strokes. So The bottom line is that even when we achieve sinus rhythm, some patients will never be off anticoagulation, particularly in our context, again, because we can't monitor them. And some of these patients are asymptomatic. The only person I'll take off anticoagulation is someone who actually can feel their AF. So if you are symptomatic for your AF, you will know when it's back. But most of the patients don't have, right? So they come in, it's a surprise that the top chamber is quivering, mama. It's not squeezing the blood. That's why you got the stroke. It's a surprise. So that's why they actually stay on anticoagulation forever. Remember, like we said, 8 in 10 folks that go for ablation of a paroxysmal AF will be successful. The other 2, which is 20%, will be back in AF. Now, the only time we'll know that they're back in AF is actually with a stroke. So anticoagulation stays, even when they're in sinus rhythm.
Phila, just tell the audience, what about the safety of EP? Because often, many times, cath lab procedures are presumed benign.
Yeah.
What could go wrong? What are some of the complications that patients need to be aware of?
Yeah.
What could go wrong in the EP theater?
Everything, right? So from access to a stroke to death on the bed, these things happen in any laboratory, cath lab, EP lab. So the one reason why we do these things so commonly now is because the complications are less, right? There's less than 1% complication rate for what we do, but they do happen. So we have to get the consent. From access hematomas to with ablation with atrioesophageal fistula, you'll remember that for AF, we're ablating in the left atrium. The left atrium lies in front of the esophagus. If we burn like crazy with the left atrium into the esophagus to make a hole between the two, which is generally deadly. So the technology is getting better, that the complications are less, but the complications are still there. It's still 1%, but they're still there. The most common complications, now I'm actually trying to convince my boss to get me an ultrasound, access, hematomas. Hematomas are very common, so we actually need to use ultrasound guided access from central line, like when you're doing your CVPs, to getting access in the groin. We need ultrasound guided access.
Let's do 2 more questions. So online one and then the other question. So Prof says, thank you for an excellent talk. Any comment on thyrotoxic patients, particularly those in high output cardiac failure, and approach to treatment?
We've generally used beta blockers as a bridge while waiting for the thyrotoxic causes of the hyperthyroidism to settle. And we've actually generally found that once we've done that, these patients actually become asymptomatic and they're back in sinus rhythm when they're euthyroid. So we wouldn't generally offer catheter ablation for hyperthyroid-driven arrhythmia AF, which is usually AF or flatter in that context. So beta blocker has a reach. And the question is, not all hyperthyroid patients actually get an arrhythmia. Why do those that get the arrhythmia get it? So we probably should still follow them up. Maybe these are the patients that have the substrate to develop the arrhythmia or the genetic disposition. Maybe in the future, they will need something else. But in the meantime, it's beta blocker while we're treating the thyroid. And we should probably take a look at a later stage, whether they really shake off the arrhythmia for real. And if they don't shake off the arrhythmia while they're euthyroid, then that's then the room for invasive interventions.
As a midwife doing general medicine, one of the most common things you experience in a patient with cardiac failure will see on an ECG would be PVCs.
Yes.
How would you select who actually needs to have those PVCs quantified and sent for ablation or not? Because I mean, as an inexperienced person, often we were told that PVCs are just associated with partly dilated ventricle, maybe part of hypertension. When do you know? How do you assess whether this patient should be sent for Holter and should be considered for ablation?
All right. So PVCs are very interesting, right? Because for the longest time, everyone, if you speak to the experienced physician, everyone thought PVCs were benign, right? Now we know they're actually not. When you look at folks that come in with PVCs versus those that do not, those guys that have PVCs in general are likely to develop heart failure down the line if they're not already in heart failure in the ward. So generally, I think when we have particularly someone in heart failure with PVCs, we have to quantify them, because when you are getting 10 to 20% of PVC, that actually tells you that the patient is getting 10 to 20,000 PVCs a day, which actually may be the driver of the cardiomyopathy. Sometimes the patient already has heart failure, but the PVCs are actually the straw that broke the camel's back, in the sense that now they decompensate because they've developed the arrhythmia. So we actually need to quantify them. And the most important thing is also we have to try and localize them. So the most common PVCs and what we call idiopathic outflow tract PVCs. So how are we going to do this? So when you have a patient with a PVC and you're seeing PVCs on the ECG, the first step is to look at lead V1, right? And look at lead V1 and say, what is the morphology of lead V1? Does this PVC in V1 look like a left bundle branch block morphology? So a PVC that is negative in V1, right? And once you've done that, you look at the inferior leads. If the inferior leads for that PVCs are positive, these are telling you that these are PVCs that are coming from the outflow tract. Now, the PVCs that are coming from the outflow tract are generally common, and they're also very easy to treat. So if you say, Pila, this is an outflow tract PVC and the patient is decompensated, chances are we're going to take this patient on because it's actually a simple procedure. So we'll quantify it, we'll localize it, and we'll define the LV function.
Just briefly, Pila, elaborate more on treating or the approach to rate controlling the burden of PVCs using beta blockers or not. In which setting are beta blockers beneficial and which setting are they not beneficial in terms of the arrhythmia? Kabo mentioned rate is a key outcome, and I'm sure the audience is thinking beta blockers, digoxin, calcium antagonism. When is it not advised to use rate control for those patients with beta blockade?
So the beta blockers are just going to be the cornerstone of what we do, right? They're readily available. So what I would want to know is the relationship of the PVCs with heart rate. So I'll do the Holter, and you will find that some patients will have most of their PVCs when they are sleeping and when they are a little bit bradycardic. So for example, you guys would know that in the evening when we're sleeping, our parasympathetic tone is heightened, right? And our heart rates are slow, they're lower. And if you're getting PVCs a whole lot during this time, it tells me that when I give you something to slow your heart down, like a beta blocker, chances are I'm going to make your PVC small, which actually happens. Alternatively, there are patients that get their PVCs mostly during the day, mostly when you put them on a treadmill or ask them to walk up and down the corridor and the heart rate increases, then they get a storm of PVCs. Now, these patients will do good on the beta blocker. So we have to actually try and see what is the relationship of the PVCs with the heart rate, which usually tells us the relationship of the PVCs with the autonomic tone.
In these patients, again, for the arrhythmia-induced cardiomyopathy.
I feel like I was presenting here. Can't hear you.
At the same time, or a similar time that they are rated, then wouldn't that prevent the need for anticoagulation?
Not necessarily. So the left atrial appendage occlusion, I think it's an area that is still growing, and we want to replace anticoagulation with LAA occluders, but I don't think we are there yet. the data is not strong enough to say that we should take away anticoagulation, particularly in people without contraindication to anticoagulation. I think the patient population that we should consider, left atrial appendage occluders, are people who are, for example, your HAS-BLED score, it comes in with recurrent GIT bleed, maybe intrableed. We'll say, should we stop the anticoagulation here and go for left atrial appendage occluder? But in anyone else who does not have those, they actually need to be on anticoagulation. Remember, like about old warfarin. Warfarin reduces the risk of stroke by a good 6%. And the only advantage we have with the NOACs is that without the side effect of warfarin. With the left atrial appendage occluders, we've seen patients that actually come back with thrombus on top of the left atrial appendage occluder. Now, if we don't have a good reason why we're stopping the anticoagulation, I don't think we should. We're not there yet.
I think also for a public health approach, it's much more costly if you're going to some LAA occluders in patients than an anticoagulation strategy. I don't think financially would appreciate that. So an LAA occluder costs in the region of about 60,000 for a patient of the team. So it's a lot of money, even for state sector.
Definitely for state sector. All right, thank you guys.
All right, it's now 9 o'clock, and I think we've had a great discussion. Thank you to Kabo for the enticing presentation. And I'm sure you all agree that there's room for us to do more for our patients with tachycardias. Our arrhythmia clinic is on a Monday. So when you refer, please be specific. Don't say cardiac clinic, it's arrhythmia clinic. And you've heard the man himself. He's willing to engage your patients and see if they're good candidates for ablation. So thank you very much and enjoy the rest of your Friday. Thank you.